Okay, now I will have my presentation now. Hello, everyone. I'm a junior student in Guangzhou Medical University. I'm very grateful to the conference organizer for inviting me and for the opportunity to participate in this conference. And thanks for the program manager, Emilia Hartley's help in getting me to the meeting. The topic I'm reporting on today is a cross-sectional study of vitamin B and bacterial vaginitis. Females in reproductive age can be affected by BV due to an imbalance in vaginal flora. The prevalence of BV varies from 20% to 16% between countries. As for 2004, the prevalence rate in the United States was 29.2%. It is noteworthy that Australia, New Zealand, and Western Europe have the lowest prevalence rates for BV. BV is characterized by the opportunities, bacterial overgrowth, and decreased level of lactobacilli. Approximately 19% to 95% of the bacteria in healthy vaginal flora are lactobacillus. BV is prone to recurrence in women receiving conventional treatment. Half of women treated for BV bacterial vaginosis experience a recurrence within 12 months of treatment. Studies have shown recurrent bacterial vaginosis has an extremely destructive impact on their health and happiness. So women need effective long-lasting treatment. This underscores the need for new therapies. Vitamin E is an essential lipid-soluble nutrient that affects crucial cellular and molecular mechanisms and the regulation of gene expression, and plays a vital role in various diseases. In the last 20 years, vitamin E has been demonstrated to regulate cellular response, including survival, inflammation, migration, secretion, and immunity. Through regulation of enzymes in signal transduction pathway, many in vitro, in vivo, and clinical researches have been conducted with alpha tocopherol, which is the most biological active vitamin E. The preventive effect of alpha tocopherol in cardiovascular disease have been reported in several cell culture and animal studies. The anti-inflammation effects of alpha tocopherol have been reported in cell culture and animal studies. As mentioned above, several in vitro and in vivo investigations have confirmed the modulatory effects of vitamin E in signal transduction and inflammation. In the last few years, our knowledge of vitamin E has gone better significantly, and the significance of understanding the metabolic authentication of vitamin E ramifications should not be disappreciated. The identification of key players involved in cellular and molecular mechanisms that are modified by vitamin E will undoubtedly lead to new treatment strategies for preventing disease progression. The intake of several nutrition, such as vitamin B, has been reported to affect the human immunity system. To our knowledge, no study have assessed the association between vitamin E intake and the probability of BV prevalence. Various studies have underway to try to identify new way to treat BV. This study aimed to investigate the association between vitamin E and BV risk to explore vitamin E supplementation as an intervention to reduce BV risk. We use data from the enhanced database from 1999 to 1906, totally 41,474 participants with data from 2000 242 participants remain after excluding data from missing variables. Of these, 43 were participants who did not have BV and 57 have BV. Afterwards, we analyzed the characteristic of the study population. Table 1 shows the characteristic of the participants in this study. All participants with BV compared to no BV were more likely to be the lower vitamin E intake and lower education, higher BMI, lower PIR, higher alcohol intake, and no marital partners, and so on. Besides, we have investigated the association between vitamin E and the BV. Table 2 presents the wet OR for BV according to vitamin E quartiles, race, and so on. Logistic regression model analyzed showed the before adjustment crew model. Vitamin E was significant negatively associated with BV risk in the third quartile in vitamin E. After further adjust for race, education, age, marital status, income, BMI, alcohol intake, and PIR in Model 2, medium to high concentration of vitamin E was still significant, negatively linked to BV. In group 3 and 4 of vitamin E concentration, there was a significant negatively correlation between vitamin E concentration and BV risk. Stratified analysis was performed for age, sex, and so on, as shown in Table 3. The association of vitamin E high concentration of BV was stable across alcohol intake and BMI and indicate a significant negatively association across alcohol intake, income, marital status, education level, BMI, age, and PIR. For vitamin E and BV, the relationship between curves is shown in Figure 2. Illustrate that the connection between vitamin E and BV is non-linear in the curve fit, from which it can be seen as the concentration of vitamin E increased. The risk of acquiring BV decreased gradually and then increased slightly. Figure 3 stratified age and showed the curve of vitamin E to BV. The risk of acquiring BV showed to reduce when increasing vitamin E concentrations when age was in the lower group. Figure 4 stratified BMI, and when BMI was in higher group with increasing vitamin E concentrations, the risk of having BV decreased when the concentration was before 1,841 and increased when the concentration was greater than that point. Among them, the trend in concentration before 1,841 was significant. Based on these results, we found that zero vitamin E was at moderate to high concentration. It was significantly associated with a reduced prevalence of BV infections. Moreover, our study found that those infected with BV were more likely to have lower vitamin E intake, higher BMI, higher alcohol intake, and no marital partners. This study provides some data to support the clinical treatment and prevention of BV. However, more evidence is needed from random controlled trials. I would like to thank my supervisor, Dr. Xu Guangguo, for his guidance, and also Guangzhou Medical University and the Third Affiliated Hospital, Guangzhou Women and Children's Medical Center for their help. That's all. Thank you for your listening.
Shakya, postgraduate student in Sri Aurobindo Institute of Medical Sciences, Indore, India, is going to present my presentation on topic Retrospective Observational Study to evaluate the role of platelet-rich plasma, that is PRP, in cases of unexplained implantation failure under the guidance of Dr. Shilpa Bhandari, who is Director and Head Department of Reproductive Medicine, Sri Aurobindo Institute of Medical Sciences, Indore, and my professor, Dr. Shazi Qureshi, she is also professor and in Department of Obstetrics and Gynecology, Indore. As we all know, platelet-rich plasma is gaining popularity as a method for treating endometrium in context of assisted reproduction. PRP is not gaining popularity for treating the endometrium, but it is useful in many other places like hairs, joints, and so on. So nowadays, PRP is playing a very popular role. So, what we did in our study is we investigated the use of endometrial installation of platelet-rich plasma for improving receptivity in the context of otherwise unexplained previous one implantation failure. We conducted this study in the women having previous one implantation failure. Okay. Hysteroscopic installation of PRP in the subendometrial region is done, and it's a novel approach for the management of refractory endometrium. The PRP is autologous plasma derived from fresh whole blood enriched with platelets. It is prepared by collecting blood from peripheral veins and contains several growth factors such as vascular endothelial growth factor, epidermal growth factor, platelet derived growth factor. These all growth factor basically improve the receptivity of endometrium by creating an inflammatory environment. As we know, with inflammatory environment, there comes the release of EGF, platelet derived growth factor. Importantly, platelet derived factors are essential for endometrial progenitor cell activity, and platelet-derived growth factor isoform significantly promote endometrial stromal cell proliferation, migration, and contractility of endometrium. Now discussing the role of platelet-rich plasma, that what it usually do because of what all the endometrium receptivity is going to improve. So basically the PRP upregulates some factor and it too down regulates some factor. It down regulates those factors who are not promoting the growth of endometrium, not increasing the receptivity of endometrium, and it increases the release of such factors which increase the receptivity of endometrium, growth of endometrium, and create an inflammatory response. So basically the PRP upregulates the estrogen receptor alpha and beta, so it increases the estrogen receptivity. Progesterone plays a very vital role in the endometrium. So progesterone receptivity is increased, tumor protein 53 is increased, C-mic protein, cytokeratin, homeobox 8 vascular endothelial growth factors, some regenerative enzymes increased by inducing the patient with PRP, stromal and mesenchymal cell proliferation takes place, and it downregulates the interleukin 1 beta, interleukin 6, interleukin 8. It downregulates the neutrophils, nitric oxide synthase, cyclooxygenase. It downregulates the fibrosis and the fibrosis related factors, that is TGF, beta 1 and TIMP1. Now moving on to the aims and objective of my study. The primary objective of my study is to assess the effect of platelet-rich plasma in cases of unexplained implantation failure, and the primary outcome measure of my study is to assess the pregnancy rate. Following is the inclusion criteria, that what all patients are included in my study. All the patients with primary infertility who had undergone previous implantation in first IVF cycles. It means they are having first IVF cycle failure. Patients having regular menstrual cycle of 20 to 35 days. Normal semen analysis having sperm density of more than 15 million, progressive motility of more than 40%, and normal forms more than 4%, or total progressive motile sperm count more than 5 million according to the World Health Organization criteria. The BMI should be between 18 to 28. Age of the females included in my study is in between 25 to 45 years of age. Patients not having any systemic, immunological and endocrine disease, and above all, the patient with written consent. Now, moving on to the exclusion criteria of my study. The exclusion criteria of my study is as follows: patients who are having age more than 45 years of age, patient who had obtained donor eggs, patient with less than 4 blasts frozen, patients having male factor infertility, and patients having tubal and pelvic factor, patients having poor ovarian reserve, and above all, patients not meeting our inclusion criteria. Now, moving on to the method of my study. The total sample size or study population in my study is 41 patients who had undergone unexplained implantation failure in previous one IVF cycle. The study design of my study is retrospective pilot study. Now, moving on to the age distribution of my study, there are two patients who are below 25 years of age. In between 26 to 30 years of age, there were 18 patients. 31 to 35 years of age, 15 patients were there, and 6 patients were there who are having age of 36 to 40 years. As BMI is a very deciding factor in a female's life, whether the female is going to be the fertile one or infertile one, it depends on BMI as well. That's why I would just want to emphasize on the BMI distribution also, that just to show that all the women who are included in this study are having a normal BMI. No one was having a over BMI. So there were around 5 females having BMI of 18 to 21, 9 having BMI between 20 to 25, 22 having BMI of 26 to 30, and there were 5 having BMI of more than 30. Moving on to duration of infertility, the 6 females were having infertility period of 0 to 5 years, 14 having infertility period of between 6 to 10 years, 11 having infertility period between 11 to 15 years, 8 having infertility period between 16 to 20 years, and there were 2 females who were having complaint of infertility since last 21 to 25 years. Now, moving on to AMH level, as it is a very deciding factor. 70% women were having AMH level in between 1 to 4, and 29% were having AMH level more than 4. The basic and the important role of platelet rich plasma is it improves the endometrial thickness, which in turn is responsible for having high implantation rate. So in this slide I am just comparing the pre-PRP endometrial thickness and post-PRP endometrial thickness. The pre-PRP endometrial thickness was 8.024, and after doing the PRP the endometrial thickness was 8.5. The time interval that we had decided to keep in between first embryo transfer and transfer after DHPRP is, there are 10 female having the gap of 3 months, 16 having the gap of 4 months, around 10 to 11 having the gap of 5 months, and around 4 having gap of 6 months after their first embryo transfer, in which there was implantation failure. Now, moving on to the outcome after doing the DHPRP and the embryo transfer, we find out that around 68% results were positive and 32% were negative after doing the DHPRP. So the conclusion of my study is, in our cohort of 41 women with otherwise unexplained previous one implantation failure, endometrial injection of platelet rich plasma led to a successful pregnancy rate of 68.3%. Larger scale studies with randomized design are needed to prove the validity of our findings. As we all know that every study has some limitations, so I would like to tell you about the limitations of my study, as it was retrospective in nature. So nature of the study does not allow for establishing causal relationship. Lack of matched control group does not allow me for generalization of conclusion, as confounding factors might be present, and the small study population. At the end, I just want to extend my hearty thanks for giving me such a huge platform to present my uh, study. I am very much thankful to everyone, to the conference, to the judges, jury, everyone who is listening to me there. I am very much thankful, and I hearty thanks from India. Okay, thank you for listening.
Thank you, Pankuri, for your
I am from DY Patil Medical College, Kolhapur. Um, so my title of the study is Effectiveness of Modified Sacroiliac Belt on Pelvic Girdle Pain in Postnatal Women. I have did this research under the guidance of Dr. Sharma sir, who is MD in Obstetrics and Gynecology. What is pelvic girdle pain is that especially in postnatal women, which is observed during in postnatal, actually after the in third trimester, and the symptom is low back pain, radiating pain towards the thigh, pain during changing the position from supine to side, etc. Mostly what happens during the discharge of the postnatal women, we as a doctor do not intervene if the pain is persistent or not, and the patient get discharged. Later, what happens? Few patients, like 10 or 15% patients, complain of this pelvic girdle pain for a long. So, what is the statement of problem of my study is that the existing pelvic belt, or there is no such a belt which is there for postnatal women. Like there are some lumbar belt are different, pelvic belt are different, abdominal belt are different. So there I have designed a postnatal belt, which I'll show further. So there are lacunas in existing belt. So this belt was newly designed again and it was studied. So the main objective of my study is to study the effectiveness of modified sacroiliac belt on pelvic girdle pain in postnatal women. My objectives were first to prepare that modified belt and study the X-ray uh, in between the 3 months gap, and to measure the qualitative improvement in pain and the quality of life in postnatal women. Uh, and to measure the quantitative data, the quantitative data was X-ray, and there were questionnaire like pelvic girdle pain questionnaire, Roland Morris questionnaire, and the is my voice audible? Can anyone answer? Is my voice audible?
Yes, you are audible.
Thank you. So the inclusion criteria was 18 to 35 years of age. Both cesarean and normal delivery included this study. Clinical tests were positive, posterior pelvic pain applications to
Dr. Vinay,
check
are
if the
you there?
pelvic pain exists or not. Yes.
Yes, she is there, and she is audible too.
Okay, thank you. And the next inclusion criteria was positive acute straight leg test and positive Patrick Saber test. Other tests were to check if there was low back pain also. Exclusion criteria was presence of pelvic girdle or low back before pregnancy, any previous surgery like spine surgery, tumors in spine, rheumatoid arthritis, and spondyloarthropathies were excluded from the study. So what you can see here is the belt which was newly designed. So I'll zoom over there. So first belt is there, that is existing pelvic belt. Second belt, what we can see on screen is the newly designed belt, which was patented by myself. It is on my name. So what difference we can see in both the belt is like first, the spine is covered by the second belt. Then there are extra, the blue straps that you can see. There are extra blue straps placed so that the pelvic belt do not slip from the treatment area. Also, the abdomen got covered. That because if we increase intra-abdominal pressure, it helps to also reduce the abdominal girth after delivery. Also, pelvic support is increased, like SI joint is covered in more, so the levels of belt have been increased to give more stability. For example, if we get fracture as the wrist joint or the elbow joint, one superior or the inferior joint is covered in the plastic so as to provide the more stability. So, what was given to the group A is existing pelvic belt and strengthening exercise, and what was given to group B was modified belt and strengthening exercise. So, what strengthening exercise was there? Especially cold exercises like pelvic bridging, then tummy tucking exercise, cat and camel exercise. Such exercise were given so as to strengthen the muscles, core muscles. So in existing belt, what is advantages as it only supports the pelvic region. What was newly invented pelvic belt? Its advantages were to support the pelvic region, also to support the low back, and also to cover the abdomen. And what was this next advantage? To reduce the abdominal girth. And the third advantage is to induce course we are able to wear it in a day-to-day activities while performing any ADL or household activities also. Here, the newly built design has only one disadvantage of that the belt has to be removed while doing for while using washroom and all. Well, disadvantages of existing belt are like there is no back support, there is less coverage of body surface area, and it tends to do not fit and slip from the treatment area. Also, it needs to be removed during using washroom and all. So, what are the outcome measure are? Here are pelvic girdle pain questionnaire first, which has 20 question and it has scoring till 3. So so the scoring comes out of 60 over here. The next is low back pain. For to analyze the low back pain, here there is Roland Morris questionnaire, which has 24 questions like does the pain persistence in. So this is Roland pain questionnaire, which has 24 questions. This is logarithmic curve. There is flexi curve ruler, which helps to measure the lordosis, as we can see in postnatal women, because the abdominal weight is more than as that of posterior body weight. And also, for example, I have placed an X-ray of one patient, which helps to this X-ray, such kind of X-rays. If we can say the first date it was taken on 21st March 24, and next it was taken on 28th June. So it is like 3 months gap was there, and then so before using the belt, X-ray was taken, and after using the belt, the X-ray was taken. Sacroiliac inclination angle was measured as an outcome measure. So the result was alternative hypothesis was proved to be effective in pelvic girdle pain. That is, modified belt was effective, while there was improvement in lordotic pressure also, but there was lack of improvement seen in sacroiliac inclination angle in X-ray. These graphs where we can see modified belt has been more useful in qualitative measures like pelvic girdle pain, low back pain, and in quantitative measure, lordosis was was quite significant. but it was not that significant. It was not in sacroiliac inclination angle. So what is the main discussion over here is the combination of pelvic strengthening protocol enhance the pelvic stability. While according to my study, what I have studied is that need of more duration of belt we have to study. Like I think we need to wear the belt for 6 months at least to see if there are any changes in alignment. As we can see in the belt, that the belt was not a non-rigid belt, it was a soft belt. So it can also be the reason that maybe rigid belt could also help to see the changes in pain alignment. And pelvic belt and exercise has proven to be superior as compared to exercise alone. Changes in pelvic belt level proves to be playing an important role in altering the pain relief, and also according to me the levels of level plays a very crucial role in pain relief. Thank you.
My title of the research is Effectiveness of Boiled Water Red Zingiber Officinale rosc for rubrum against perineal wound pain in postpartum mothers at the clinic primary Trismalia. I am Ismesrida Simarmata and my team from Indonesian University Stikas Mitra Husada Medan. Okay. Perineal wound pain is happened one consequence to exhibitors from rootworm as a result of the implementary period. The perineal wound disturbs the feeling of comfort and uterine involution because not enough immobilization. Perineal wound occurred spontaneous or episiotomy, and then pain management, seed baths, cold, lavender, scan, and boiled water rendered red. Red ginger has proven as an anti-inflammatory because contain ginger 6 gingerol. His mediators can cause activate NF-kappa beta, COX-2 is inhibited. Research results previous erode proven perineal wound more fast help drink boiled water red ginger. Resistor cytokine inflammation, red ginger contains functional 6-sogol as anti-inflammatory, inhibits COX-2 so that lower PGF2 level and decrease intensity painful perineal wound. Initial survey, postpartum mothers who experience perineal wounds all feel pain. For analysis effectiveness of boiled water ginger red lower perineal wound pain intensity. Methodology study, quasi-experiment, design posted only control group design, population and sample is mother's perineal wound pain, consecutive sample 32 respondents, years 2020, clinic primary Trismalia Deli Serdang. Research making boiled water red ginger red, grated brown sugar, 1 and much as 25 grams, boiled in the 1080 100 cc water, drink 30 times 200 cc for 3 days, and measure perineal wound pain intensity, use short observation with use visual analog scale, and then control drink water, treatment drink boiled water ginger red 200 cc 3 times a day for 3 days. Hypothesis test using the t-test independent for analyzing difference intensity of both group. Result, Majority is 35 years, and then we and then pain intensity of both groups. Group pain intensity score, maximal score 4 and minimum score 2. Pain intensity group treatment, maximum pain intensity score 2 and minimum score 0. Analysis bivariate comparison pain intensity in both group is group mean control 33, 20, 22, and group treatment 1. T-test independent test PP 0, 0, 0, 0. There is a difference for intensity painful after drink boiled water red ginger. Discussion univariate test characteristic respondent egg and education egg because healthy egg for the reproduksi egg reproduksi organ still good, and then high school still ACS than the director that will be given. Occupation parity degree and perineal wound, work majority mother house, and then parity both primipara and multipara. The degree of perineal injury is the same as in grades 2 and 3. Pain intensity in both group after 3 days. Group score control painful 1 max mean 4-2 mean 322. Group score treatment painful perineal 1 max mean 2 and 0 and mean 1. Extract ginger red 50 milligrams contains oleoresin with substance active gingerol function as an anti-inflammatory. Ginger proven can functioning as an anti-inflammatory with gingerol content which can hinder COX-2 pathway in formation of TGF-2 alpha. As cytokines trigger, they occur painful. The result of other studies are also known that the technique lower at a time speed up the decline painful. Thank you very much.
Everyone for being present today for this presentation of mine. This is a research that we did a couple of years back while I was still a student in one of the finest institutes in India. It's in Sir Gangaram Hospital in New Delhi. And this was a finding of his morphological and histopathological examination of placenta. And we tried to find out its correlation with the neonatal outcome. And this was done actually in normal cases and SGA pregnancies. Okay, so I'll just give a brief outline of this entire study. So the objective was basically to study both the morphological characteristics and the histopathological characteristics of the placenta. And we took the SGA and the low risk pregnancy. So the control group was the low risk pregnancies. That means there was no confounding factors. That means there was no high BP or sugar or any other comorbidity. And then we took SGA pregnancies. That means the ones which were having, I'll elaborate it further in the materials and methods, the pregnancies in which the weight of the baby was found less than 10th centile. And it could have, preeclampsia, it could have diabetes, it could have hypothyroidism, it could have placental dysfunction, and that was not differentiated from FGR, just SGA. And this was associated, so this was studied, and it was the features were associated with the neonatal outcome. So just a minute. Right. So the term for this thing SGA, which we are using in this in the study, is actually for the fetus with a birth weight of less than 10th customized percentile or less than 2 standard deviation for the population reference. And that might not be pathological. That means we've taken it SGA. It could be FGR as well. We've not differentiated it. That was a part of the study. So FGR becomes actually a pathological state, which is based on the additional criteria of estimated birth weight less than 10th centile. poor somatic growth, or a compensated umbilical or cerebral blood flow. Placental dysfunction being the major contributing factor to the fetal growth restriction. And placenta-mediated fetal growth restriction occurs basically through the chronic fetal hypoxia, owing to poor placental perfusion through a variety of mechanisms. So maternal malperfusion happens to be the most common placental disease which contributes to the fetal growth restriction. And with this background, we proceed further. So this is one of the real-time pictures which we took from our own labor room. This is the fetal side. This is the maternal side. So we see basically over here, okay, the number of cotyledons, the number of calcifications we can see over here we can see, this clots. Somewhere over here we can see certain infarcts, okay, and very small micro calcifications also can be seen, but it is not visible in this camera image. So again, an outline. So the features of maternal vascular malperfusion, they are identifiable on placental pathology, antepartum diagnostic methods, and they are still evolving. The placental imaging and uterine artery Doppler play an increasingly important role, and they are one which help us find out if there is any problem with the placenta per se. The perinatal outcome of the fetal growth restricted fetuses, it's largely dependent on the severity of growth restriction. And we've seen that those fetuses who have less than third centile or abnormal umbilical artery Doppler measurements are at the greatest risk of having any adverse outcomes. So there is no clear evidence of concordance between the lesions of the placenta and the clinical disorders, but placental pathology can, give a suspicion and provide additional information. And it definitely is a very important tool to be used in medical litigation in cases of adverse neonatal outcome. The aim of the study, therefore, was to evaluate the placental pathological findings and which are in pregnancy, which are complicated with SGA, and then we associated its clinical outcome. So this was the materials and methods used. This was a prospective observational study, and this was conducted in our department, the Department of Obstetrics and Gynecology in Sir Gangaram Hospital. This is almost 1,000-bedded hospital in New Delhi. And this was a study way back in 2007 to 9. And here we took 100 placenta from pregnancies diagnosed with SGA fetuses, and we compared it with 100 placenta from uncomplicated pregnancies. They were taken as control. And these two populations, they were taken with after filling a proper performa and taking due consents. And we had a exclusion criteria for the study group. That means we're not taking patients with multiple pregnancies or previous infections. We knew that they are not having any thrombophilias or extremes of age, extremes of weight. So these confounding factors we did not take. Okay, no history of smoking, alcohol, or of substance abuse or any abnormality of the fetus. These were not taken. And we took singleton pregnancies, and we took estimated fetal weight below 10th percentile. I'm not saying anything about the deranged Doppler flows. Pregnancies with accurate gestational age dating. Okay, so there was no confounding factor relating to any, mixed up dates or forgotten dates or some confusion with the dates. After the delivery, the placenta, they were macroscopically analyzed. Like I just gave you a brief understanding as to how we used to morphologically see if there is any gross abnormality, an extra lobe or some cotyledon missing, or basic obvious infarcts, or small microcalcifications, or we see that there are thrombi, we're seeing clots in between. There are certain, lobules of placenta which are completely thrombosed, which are literally not functioning, or a very small placenta, or a very large placenta, or a placenta which is showing almost half of the part of the placenta which is looking unhealthy. So these were seen after the delivery. The macroscopic aspect of the placenta, they were analyzed in the labor room and in the OT. And the placenta, then they were sent for histopathological analysis, of course, in the formalin. And these particular histopathological findings were seen. The villus infarcts, the arteriopathy, villitis, specifically periphyllous fibrin deposits, decreased vascularity, diffuse calcifications. These are all histopathological analysis. Now, the fetal outcomes evaluated were whether the patient finally goes on to have a preterm delivery, or there was a low birth weight of the baby, or the Apgar score was less. And by less, I mean less than 7 at 5 minutes, or the baby finally had a neonatal death. And then the establishment of association between the placental lesion and the neonatal outcome was then attempted. And now let's understand what were the results. So because we had excluded the extremes of age, we found the age distribution between the study group and the control group almost equivalent. And here is the figure. See, it's almost equal in distribution. So we had actually, this is a reason that we had already excluded the extremes of age. Now, finding out the majority of the females, they were found to be primary gravida. See, in case of the study group, we saw that here, you see, most of the SGA babies, they were actually from the primary gravida group. So that was a thing, it was striking, which shows a stronger correlation of the SGA with the first pregnancy. Okay, that is one important aspect. Since we excluded the extremes of weight, we found comparatively higher distribution of weight in the study group as compared to control group. Again, this is not very, the thing which to ponder on, because we have excluded the extremes of weight, which is again a very important confounding factor that could be a reason for SGA fetuses, but we have excluded it. And we analyzed this entire data by a paired chi-square test, because it was the lesion was either there, yes, or the lesion was not there. So it was a chi-square test. And then association was also between individual placental lesion. That was basically again, by a chi-square test with the help of percentages. On studying the weight distribution, when we saw the weight distribution, we saw that in the study in the control group, we found that 37 of the placenta of the study group, they weighed less than 400 grams, which is pointing towards a greater correlation of decreased placental weight and the SGA pregnancies. So you see, over here, this was coming to be statistically significant. Okay, so see this part, less than 400, you see that the cases, that means the study group has shown a very stark rise as compared to the control group, and that is statistically significant. Even the gross morphological abnormalities like infarct, hematoma, they were found in 68% of the study group, they exhibited these problems, and 72% of the control group were normal. So again, this was statistically very, very significant if you see this part. See that the controls are normal, and here in cases there is some or the other morphological problem. Either there are increased calcifications, or there is abruption, or there are infarcts, or the size is small, some abnormality was there. So again, that was statistically significant. Amongst these histopathological findings that we saw in the study group, this over here is a brief highlight as to exactly what we found. And here I'll show it with the help of these bar diagrams. So we saw, if you can see, the diffuse calcification, again, more in the cases, some similar thing you see in decreased vascularity, perivillous fibrin deposits. And these are actually those lesions, especially decreased vascularity and perivillous fibrin deposits, which I want you to mark, because finally we found the significance in these two cases only. Diffuse calcification, though it looks more in cases, but it was not very statistically significant and did not have a very important result by the end of the study. So these two came out to be the most important lesions, the decreased vascularity histopathologically and the perivillous fibrin deposits. And we found that around 82% of neonates, they were delivered before 37 completed weeks in the study group, again, which was a very significant finding. Over here, you get to see this, that most of the control, that is the control population, the low risk population, they had deliveries after 38 weeks. And because of so many reasons, we had more deliveries, which is interspersed between less than 38 to, even 34 to 35 weeks. See the amount of deliveries we had between this time. And these are all cases. So because cases, they were having a lot of other problems, like maybe preeclampsia or GDM or hypothyroidism, or just maybe deranged Dopplers along with FGR. So there are so many reasons for having early deliveries. So the finding of 72% neonates in the study group with birth weight less than 2 kgs was expected. We expected this because we took SGA babies. Okay, that was obviously a statistically significant finding. And we observed that despite preterm delivery, the Apgar score at 5 minutes for the study group was more than 8 and 62%, which is probably the effect of non-pathological. Is a possibility that we did not separate SGA from FGR. So maybe this is the reason for a good result that we're having. Despite an early delivery, we got good, healthy neonates, that is above Apgar score more than 8 in almost 62% neonates, which is a very encouraging thing. But at the same time, it gives one, a facet of the study that maybe that we also include non-pathological SGA, which is the reason why we had this good result. And you get to see something over here. So less than 1.5, you see mostly the green, that is the cases, have more cases, less than 1.5. Okay, and still we had an encouraging result. And many of them, so there were hardly any stillbirths, but whatever they were in the cases mostly. And the ones which went baby along with the mother was most in the control and less with the cases. So they went mostly in the NNU or in the ICU, because of whatever reasons. And this again is very encouraging, that despite the fact that we had an early preterm delivery for most of the cases, but we had a good UPGAR score. So we headed up to establishing the relationship between individual placental lesions and neonatal outcome, which was a very challenging part of our study, but it finally gave us some very important results. We saw that our study failed to demonstrate any significant correlation with major placental lesions, but at the same time, we saw that in perivillous fibrin deposition, it showed significant correlation. Okay, so we saw that perivillous fibrin deposition, it showed significant relation over here with the UPGAR score, less UPGAR score, that is less than 7 at 5 minutes. Perivillous fibrin deposition was a very important factor. And that could be because of inflammation, infection, whatever, one of these reasons because of which there was a fibrin deposition around the vascular supply of the baby. And when we compared the placental lesions with decreased fetal weight, we saw that decreased vascularity is closely related with decreased fetal weight. Okay, so these two lesions came out to be very prominently associated with the corresponding factors. So decreased vascularity was related to decreased fetal weight, and decreased perivillous fibrin deposition was related to depression of UPGAR score at 5 minutes. And a quick discussion. So our study found that mean distribution of the placental weight in the study group was in the lower range. And the same thing was found by Maria et al. She also found that the placental weight is decreased in the study group as compared to the control group. And she was studying the placenta and the pregnancies which were complicated with a fetal growth restriction. Then we found that the placental infarctions, they can be found both in normal and abnormal pregnancies, okay? And this lesion presents clinic morphological significance when it affects at least 10 to 20% of the placental volume. And Jaco et al., they presented a research in which the calculated volume of the placenta measured the time of delivery. That showed a stronger correlation with the birth weight as compared to the association between placental weight and birth weight. So you need the whole volume of the placenta at the time of delivery rather than just the, basic bare-line placental weight. So these were certain findings which we saw. We found the incidence of perivillous fibrin, which I just elaborated upon, statistically significant, which was also found out in the study by Maria et al. And this decreased vascularity, which we saw correlated with the fetal weight. This was again seen in the study of Iskender and Mazmal. So these were encouraging results. These were results which were repeating. That means they were closely associated. And again, the same thing I would like to, impress upon, that again, we found perivillous fibrin deposition as the only placental lesion which showed significant correlation with adverse neonatal outcome. I'm talking in terms of low and decreased UPGAR scores. And on establishing an association between placental lesions and the birth weight, we found again that decreased vascularity has a significant correlation. So these two were coming out very strongly. So through our study, we found that though SGA fetuses, they are more commonly associated with histopathological abnormalities, it cannot be established whether these abnormalities certainly they contribute to FGR. So of note, the malperfusion lesions of the placenta, which show close relations with not only FGR, but decreased fetal weight and poor neonatal outcome. And that was shown in our study. We also found that the association of perivillous fibrin and decreased vascularity, they significantly correlated with the adverse neonatal outcomes. And this suggests that vascular changes in the villus structure, they are very important causal factors for fetal distress and possibly a poor neonatal outcome. But obviously, we need more studies for further comments. And one very important aspect about my study was that there was the presence of many confounding factors in the patients. Then they were difficult to delineate, okay? Age, socioeconomic background, gestational age, age on diagnosis, age on delivery, pre-pregnancy BMI. So these, the co-occurrence of placental lesions maybe she also has perivillous fibrin along with decreased vascularity and calcification. So co-occurrence of placental lesions in the study group, they could have been a confounding bias in the results. So these were a couple of limitations, and with this, I thank everybody to being so patient, being available, and again, I thank you, everybody associated with this conference, for giving me this opportunity to put up this study of mine on this international platform. I thank everybody to be present for this lecture and all the organizers who made it possible. Thank you so much.
Thank you so much, ma'am. Your session was a standout contribution to this conference.
Is an undescribed technique. We present a video of our fibroid extraction technique by posterior colpotomy with this system. Removal of fibroids by posterior colpotomy by robotic surgery in 7 steps. Access to abdominal cavity and docking of robotic arms using a direct vision trocar without any complication to the entrance. We use normally a 20 degrees Trendelenburg or more for the positioning of the patient. 14 centimeters and an elevation of 2 centimeters were used in this patient. Of course, this has some variance in other patients. Normally, this is the minimum of distances that we use. We put an access trocar for the bedside near the palmar point. Now we use laser for synchronizing the alignment of the robotic arms with the patient. And we proceed for the docking using the angles, as you can see, as a reference of the head and the feet of the patient. Now we are putting the instruments, normally the monopolar at the right hand and the bipolar at the left hand. We start to visualize the uterus and decide the approach that we're going to use. We infiltrate with vasopressor solution the myomas for avoiding bleeding in every case that we done. Now we proceed to cut and make the dissection of the fibroids and taking them out. This technique is a usual technique as laparoscopic approach also, but in this case we get the benefit of ergonomic instruments. Now we proceed with another myoma. Of course, we're using the help of a tenaculum by the bedside, and this helps us to avoid the necessity of a fourth arm. Finally, we use energy to avoid bleeding, and then we start to suture the patient using Spalding points. This is the kind of suture that is used for the baseball balls that you can see them. That's the name. That's where comes the name of Spalding points. We enter inside and go out in each side, as you can see. And the robotic arms are very helpful in this kind of movements. There are complicated movements for the process of suturing, align and getting also hemostasis at the same time. Then we cut the suture. We normally use Veloc 90 20 for this procedure. Now you can see that we are making sutures to the fibroids, and we unify them with these sutures, looking for avoiding any problem of losing fibroids during the procedure. At this point, we are using a vaginal structure called CCL structure stored. We made an incision between the uterosacral ligaments, and we open the cul-de-sac of the vagina. Then we are going to pass an endocatch of 15 centimeters, so we can put the myomas inside and we can get them out without any danger of spilling or that we lose the myomas. As you can see, it's pretty easy to do this, no problem at all. And of course, we need to have a very good coordination with the assistant that is in the vaginal approach using the trocar. You see in the image aside how they take out the trocar and also the back with the myomas inside. We don't need to take out the manipulator, so we can still use it for the process of suturing the vagina. Then we proceed to close the vagina, also with VLOC 90-0. And we have to say, it's very complicated to do this kind of sutures in the dip of the pelvis by conventional laparoscopy. But as you can see, with robotic systems, it's really pretty easy to do this suture, even though we are really deep in the pelvis. When we finish this procedure of suturing the vagina, all the surgery has been done. We have done this procedure a lot of times, and by right now, we don't have any complications related to infections or other complications at all using this technique for extraction. Now we are using Polysorb 2.0 for a hemostatic suture in this part that we took out one of the myomas. As you can see, the ergonomic and easy movements that we can apply with the robotic systems help us a lot to do the knot that needed for this suture. Finally, we use a hemostatic mesh for covering the uterus and the cul-de-sac. This will help us with the hemostasia and also will help to prevent adherences to the area that we just operate. The extraction of fibers by colpotomy in robotic surgery is a viable alternative, easy to perform, and fully replicable, where excellent results are obtained, maintaining the benefit of robotic surgery with better aesthetic results and lower risk of dissemination of hidden malignant. Vamos a repetir la conclusión. The extraction of fibers by colpotomy in robotic surgery is a viable alternative, easy to perform and fully replicable, where excellent results are obtained, maintaining the benefits of robotic surgery with better aesthetic results and lower risk of dissemination of hidden malignant tumors.
And the possible protective role of vitamin E. Hepatitis C virus infection is a major health problem worldwide, and its eradication is mandatory. Direct-acting hepatitis C virus polymerase inhibitor, such as sacroiliac or SOF, is an effective regimen. However, it has some side effects like mutagenesis and impairment of testicular function. The old hepatitis C virus treatment regimen, interferon and ribavirin, were shown to affect the ovarian reserve in treated women in previous studies. It was also important to evaluate the safety SOF on the ovary, as there are no studies yet. Increasing the production of reactive oxygen species cause oxidative stress, which affect ovulation process, female reproduction, and fertility. Accumulation of SOF in the cell was demonstrated in previous studies to promote reactive oxygen species generation. Vitamin E is an oxidant agent that has an essential role in the female reproduction system, and its deficiency can cause infertility. So the aim of this study is to explore the effect of SOF on rats' ovarian tissue through exploring the morphological changes in ovarian cortex and medulla, and the role of reactive oxygen species in SOF cytotoxicity pathogenesis using biochemical and immunohistochemical studies. Also, to explore whether vitamin E could be a protective agent against cytotoxicity of SOF in a trial for better understanding of the drawbacks of SOF in ovarian function and try to protect against it. So we chose markers to follow up with the drug cytotoxicity. We chose two proliferating factors, PICNA and the Ki67 antigen. They are essential for cellular replication, and its expression affect mitotic activity. And it is usually used as an indicator of cellular proliferation. Those markers used to follow up with the drug on drug cytotoxicity and the proliferation on ovarian follicle. The other marker is apoptotic marker, CASPAS3, is one of the most significant apoptotic causes related to intracellular protein proteolysis and to the apoptotic morphological changes. Its activity measurement help for assessment of the cytotoxicity of certain drug or chemical on ovarian tissue or cell. So we allocated 24 virgin females Spurge Dowley rates. Its age averaged between 6 to 8 weeks, and its weight averaged between 125. Animal experiment was performed, of course, in accordance with the guidelines of principles of lab animal care. The rats were divided into 4 groups, 6 rats each. The negative control group fed basal diet and sacrificed to be compared with other experimental groups. The second group is SOF treated group. It was given SOF orally 40 milligram per kg for 1 month and sacrificed to confirm its effect on the ovary. The sham group or vitamin E group, it was given vitamin E for 1 month to investigate whether it has any effect on the ovary. And the fourth group is the co-treated group. It is co-treated with SOF and vitamin E for 1 month, then sacrificed to explore the potential protective role of vitamin E on the ovaries. After 30 days, the rats were sacrificed and the ovarian sample were collected and prepared for chemical, histological, immunohistochemical studies to explore the effect of the SOF on ovaries and the potential protective role of vitamin E. And here we go. We found significant upregulation in the oxidative stress marker, nitric oxide, and MDA, lipid peroxidase, in the SOF-treated group, and this was reversed after co-treatment with vitamin E. Also, we found downregulation in the antioxidant enzymes CAT, SOD, GSH, in the SOF-treated group, and this was reversed after co-treatment with vitamin E, confirming the oxidative stress effect of the SOF drug and the antioxidant protective role of vitamin E. In the histological studies, hematoxylin and eosine sections in the control group, the ovary showed healthy Gravian follicle in multiple stages. The stroma was also mildly vascularized. However, in the SOF-treated group, in image B and C, there was atretic follicles. There was congested dilated blood vessels in the stroma. There were also multiple vacuolation, indicating the injurious effect of SOF on the morphology of the ovary. D is the vitamin E treated alone group. It was noticed multiple corpus luteum higher than normal in this group. And in the co-treated group with SOF plus vitamin E, the healthy Gravian follicle reappeared, and the stroma showed again mild, less congested medulla. In this histogram, we counted the number of healthy follicle, corpus luteum, and atretic follicles. In the control SOF, vitamin E, and co-treated group, we noticed significant reduction in the number of healthy follicle and corpus luteum in the SOF treated group. However, the atretic follicle was markedly increased. And in the co-treated group, there is reverse. The reverse happened. There is increase in the significant increase in the healthy follicle corpus luteum and significant reduction in the number of atretic follicles. For the immunohistochemical study in the BICNA stain, we found the BICNA positive cell least in the SOF treated group as compared to the control vitamin E and co-treated group. Here we did image analysis to measure the stained area as a proliferative index. In the SOF treated group, it was significantly reduced and significantly increased in the co-treated group. Regarding Ki-67, it stained the nuclei of the Gravian follicle, granulosa, and Zika cell. It was intense in the control. It was negatively stained in SOF treated group. And in the vitamin E, it was similar to the control. And in the co-treated group, this positively stained cell reappeared. And here is the area percentage proliferating index. It was the least in SOF treated group, and it reversed. It was significantly higher in the co-treated group. Finally, the apoptotic marker, CASP3, it was detected in cytoplasm of lutea and granulosa cells. It was higher in the SOF treated group, indicating apoptosis, as compared to the control vitamin E or key co-treated group. Also, the area percentage, it was higher. It was higher in the SOF treated group and reduced in the co-treated group. So in sum, this in vivo experimental study anticipates a biochemical and immunohistochemical evidence of SOF role in oxidative stress induction that pursued to ovarian morphological dysfunction. It also demonstrates the essential role of vitamin E as antioxidant agent in protecting the ovarian tissue from the effect of oxidative stress markers and preserve its function. This could be a guide to add vitamin E supplement to SOF regimen to prevent its harmful reproductive adverse effect, especially in women. I'd like to thank other members who participated in this study. The study was published in the Anatomy and Cell Biology journal. Thank you.
So thank you so much, Dr. Nivi, for the excellent presentation. I hope the audience have learned more about it. So any question from the audience?
For the medicine as well. And it has been studied for more than 100 years, but to date, none of the proposed therapeutic strategies has provided a complete cure or avoided recurrence of the disease. And there are more than 10 theories proposed to explain the etiology and pathogenesis of the endometriosis. And here you see 5 main theories, and the well-known Sampson's theory of retrograde menstruation, when the menstruation blood retrograde flow into the cavity, abdomen cavity, and the coelomic metaplasia, when the scientists believe that metaplasia on the surface of the ovary can be transferred into the endometriotic lesion. Embryonic theory is quite the same as the coelomic metaplasia, but the scientists believe that in the embryonic embryogenesis, there are some tissue samples lived in the ovary that can further develop into the endometriotic lesion. Stem cell theory and epigenetic theory. So today, as I mentioned above, numerous treatment strategies for endometriosis have been proposed. It is also necessary to highlight the risks of the developing atypical forms of endometriosis as a base for the formation of endometriosis-associated tumors. What are the therapeutic strategies now in the immunosuppression? And the most immunological studies of endometriosis were experimental and use the laboratory animals such as mice, baboons, and rats, and etc. And to test the effect of immune system and the possible role of immunosuppression in endometriosis, an animal model was implemented. Scientists know that the olive baboons develop endometriosis spontaneously as the human, and they are the best model for tracking the course of the disease. And even in 1995, Dr. De Hooch and the colleagues treated female olive baboons with immunosuppressive therapy in combination even with methylprednisolone and azathioprine doses similar to pharmacotherapy after allogenic heart transplantation, quite high doses. And the female baboons with spontaneous endometriosis showed an increase in the just a minute. And surface area of lesions and the later stage of the disease in accord with the classification of American Fertility Society. And the development of the endometrioid ovarian cyst were the result of treatment with azathioprine alone. So at the beginning of the experiment, healthy baboons were subjected to identical therapy and remained free of endometriosis. And moreover, surgical induced lesions did not respond to immunosuppressions. And this study was an important warning and showed the indiscriminate and arbitrary use of immunological treatment previously readily offered to patients with infertility or habitual miscarriages can lead to the abolition of immune surveillance, paradoxically worsen the course of endometriosis and worsen the results of infertility treatment. Here is the scheme of the site of endometriosis, and the numerous biological factors and immune factors affected the endometriosis focus. So there are some targets with some drugs that can lead to the stoppage of endometriosis growth or even the cure. And what about inflammatory cells? As we know that endometriosis often always have a lot of inflammatory cells with a lot of sites and effects that are immune cells dependent. And So there are new application points for the treatment of endometriosis, include innate mononuclear phagocyte system, cellular population of immune cells, T and B cells, and as well as rare populations such as mast cells. The great attention is paid to monocytes and macrophages. And they are known to be able to stimulate angiogenesis and innervation of the lesion that can cause chronic pain syndrome and as well as some phagocytes effects. An increase in proportion of results resting in regulatory T cells and partially activating regulatory T cells in women with endometriosis was demonstrated. And also, it is what phagocytosis in macrophages, which is activated by transforming growth factor beta. These observations may be associated with suppressed immune responses and can initiate and contribute to the development of endometriosis in pelvic cavity. So in patients with endometriosis, it was known that population of macrophages is significantly higher in peritoneal fluid and ectopic endometrium, and there are numerous studies about this fact. It has been shown that macrophages penetrate into endometrioid foci in great numbers, then into a healthy peritoneum, both in patients with endometriosis and women women of the control group. And macrophages play a crucial role in development of endometrial foci and inflammation and even their fibrosis. In particular, peritoneal macrophages in patients with endometriosis have reduced phagocytic capacity, which is associated with the reduced expression of CD36 receptor class B lymphocytes compared with macrophages of control group women. And what is not well known is the role of mast cells in the endometriosis lesion. And it is known that mast cells express estrogen and glucocorticoid receptors. Their number increases with aberrant endometriosis and correlates with pain syndromes, as well as the grade of fibrosis. And it in vitro studies indicate that prostaglandin E2 can modulate the release of active granules in mast cells and stimulate nervous activity, and the nervous activity leads to the chronic pain syndrome. Mast cell stabilizers have been studied in preclinical models as potential treatments for endometriosis-related pain, and with some in believing success of these preclinical models. So what about inflammatory biomolecules that can be the target for the treatment of endometriosis? And the member of interleukin-1 cytokine family, including interleukin 33 and 1 beta, their receptors appear to be promising targets for novel therapeutic intervention. Evidence obtained from mouse models suggests that monoclonal antibodies directed at these ligands may be effective. And there is also evidence that inhibition of the downstream myeloid differentiate factor 88 signaling pathway can reduce lesion volume. And in the context of inflamed endometrium, pharmacological effects of selectively inhibiting prostaglandin receptors were investigated using a mouse model of endometriosis. And it was found that the functionality of the endometrial tissue can potentially be restored through the interaction of this prostaglandin, estrogens, and progesterone. And the results indicate that inhibiting prostanoid receptors reduce synthesis of prostaglandin E2, and well as the production of pro-inflammatory cytokines and increased progesterone signaling in ectopic endometrial tissue in women with endometriosis. That is very important fact through the endometriosis associated infertility. And immune control points even were investigated in the endometriosis. And it has been suggested that dysfunction of natural killer cells and CAR cells in the endometrium may contribute to the immune response, leading to the release of ectopic endometrial tissue into the abdominal cavity. And the recent studies have shown that the levels of ligand 1 for the programmed death receptor, PDL1, and programmed death PD1 are increased in endometrial tissue compared to healthy one. So, the findings suggest the PD1, PDL1 signaling pathway may play a role in immune resistance in endometriosis, and immunotherapy has been proposed as a potential treatment for the endometriosis targeting in the activity of natural killer cells. And NK cells express inhibitory receptors of their surfaces that prevent them from attacking ectopic and cancerous cells. And drugs that target the PD1 receptor and its ligand, PDL1, have been successfully used in cancer immunotherapy, as we all know. So the research on NK cell-simulated endometriosis treatments can be categorized four main areas: blocking inhibitory receptors, inhibition of cytokines, particularly TGF-beta, stimulation of interleukin-2 producing NK cells, treatment with mycobacteria using BCG, Bacillus calmette. The pain management is very important in treatment of endometriosis, and the pelvic pain associated with endometriosis also involves alterations in the chemical makeup and functioning of the brain in the responsible for pain perception. And these findings underscore the significance of the central pain amplification in the pathogenesis of endometriosis-related pain and the necessity for further investigation into the application of neuromodulatory medication aimed at addressing central pain dysregulation in women with endometriosis. And an alternative approach may involve directly targeting the nerve involved in pathways. For instance, the use of neurotoxic injections such as botulinum toxin has been explored as a treatment for women with myofascial pelvic pain syndrome. And in these conditions, 74% of patients have reported symptom improvement. The gene targets is a novel target in the endometriosis treatment, and MIR, a small non-coding RNA ranging in the length of 19 to 25 nucleotides. Since endometriosis is a disease involving chronic inflammation and angiogenesis, it is possible that MIR from blood and peritoneal fluid may influence the initiation and projection of the endometriosis. So there are several studies that have shown the expression profiles of MIR in endometriosis and endometrial fossa deeper, and the inherited polymorphisms of MIR-LED7 transformation into KRAS proto-oncogene may be caused by abnormal endometrial growth and endometriosis. So this discovery echoes the molecular genetic results showing that KRAS is the most frequently mutated in endometriosis, and quite a lot of studies have supported this fact. And angiogenesis, how to cope with the angiogenesis in the endometriosis. So there are some glycoprotein receptors named galactins or GALs that specifically interact with B-galactoside ligands. The expression of GAL3 is known to increase the production of the factors such as VEGF and its receptor VEGFR2, leading to a shift in macrophage polarization towards the M2 phenotype. This shift is associated with the release of anti-inflammatory factors that promote tissue repair. GAL3 is commonly overexpressed in the peritoneal and deep endometrial tissue of women with endometriosis, as well as in the ectopic non-diseased endometrium of these patients. So the inhibition leads to a reduce in lesion size and angiogenesis, as well as the decrease of number of macrophages and angiogenic markers. And additionally, treatment with GAL3 reduced the expression of TGF-1, which contributes to downregulation of VEGF levels and polarization of macrophages toward the M1 phenotype. Alarmins, as known as damage-related molecular patterns, are immune-stimulated endogenous molecules that are released in response to tissue damage or inflammation. And as a well-known interleukin-33 is an alarmin that is associated with endometriosis. And elevated concentration of this biomolecule were observed in the blood, serum, and peritoneal fluid of women with deep infiltrated endometriosis compared to the healthy controls. So this molecule present in the microenvironment, and in the mouse model of endometriosis without intraperitoneal injections of this molecule have been demonstrated that stimulate systemic inflammation and promote growth and vascularization of the lesion. So, considering these data indicating the active role of interleukin-33 in the progression of the endometriosis, neutralization of this molecule can also serve as a potential pathway into the therapeutic intervention. And fibrosis is the most dangerous thing in the endometriosis, leading to infertility, pain, and adhesions in the abdomen cavity. The inflammatory response associated with endometriosis is responsible for secretion of cytokines by leukocytes, which stimulate the proliferation and activation of myofibroblasts. And they secrete pro-inflammatory cytokines, regulating immune cytokines, and enhance the fibrous response. So, in vitro studies, the active sphingolipid sphingosine 1-phosphate S1P is involved in inflammation and immune response and altered in endometriosis, and is the target that can be regulated. So, in conclusion, in the management of the endometriosis, it is essential to provide individualized treatment that incorporates sophisticated decision-making process, such as intelligent text analysis, neural networks, and other advanced technologies. These tools enable the integration of genomic, transcriptomic, epigenomic, proteomic, microbiome data, as well as information on patients' behavior and computer-aided analysis. Furthermore, conducting more multi-center randomized controlled trials is crucial to evaluate various treatment modalities for endometriosis in terms of their effectiveness and achieving specific outcomes such as alleviation of pain and infertility restoration. This approach not only enhances the quality of life for women with endometriosis, but also contributes to a deeper understanding of the disease and its management. Thank you for your attention.
So
was in Middle East, it was reducing cesarean delivery rate in NTSV, which is the nulliparostum singleton vertex presentation. So cesarean section is one of the most common surgical procedure worldwide. Cesarean birth is performed when this method of birth is believed to be more beneficial for the mom and the fetus than the vaginal delivery. NTSV include low risk, first time mom, nulliparous, singleton, no twin with gestational age at or beyond 37 weeks with vertex presentation, no breech or transverse lie, who underwent CS following either spontaneous or induced labor. By decreasing the C-section rate in this low-risk population by improved quality care, we can lead a healthy outcome with cost effectiveness. So what is Quality Improvement Initiative? It is a structured effort aimed at enhancing the performance, process, and outcome of a system or organization. In healthcare, for example, quality
improvement initiative focus on improving patient outcome by enhancing the patient safety, increasing the efficiency, or reducing the unnecessary cost. These initiatives often involve analyzing the current practices, identifying the gaps and areas of insufficiency, and implementing data driven changes to address these issues systemically. So why this is alarming? Because CS rate is a global as well as local concern. Over the years, globally, the CS rate has been significantly increased from around 7% in 1990. Nowadays, it is range up to 21%, and acceptable CS rate by WHO is recommended 10 to 15%. So these trends are projected to continue to increase over the current decades, where both unmet needs and overuse are expected to coexist, with the projected global rate up to 29% by 2030. So in high income countries, including UK and US and Australia, the CS rate have consistently exceeding 30% in many settings. So what is it is costing to the healthcare system? So medical interventions are currently overused in low risk pregnancies, which led to overtesting during pregnancy, and upward trends in cesarean section in turn increase the medical cost. Reducing unnecessary cesarean section can elevate financial pressure on a healthcare system, including NHS. A key reason for focusing on this topic is the significant variation in the CS rate across the hospitals and region. By addressing the variation, hospital can standardize the practice and reduce unnecessary C-section. Why this significant variation in pregnancy in the practice? Because of the patient preference, provider attitudes, and the hospital policies. Why NTSV? NTSV cesarean delivery rate has been recognized as a meaningful benchmark. Variation in NTSV cesarean delivery among hospitals and the providers suggests many hospitals may be able to safely improve their rates, lowering the NTSV rate without compromising safely. The major focus on the quality improvement efforts to ensure better maternal and neonatal outcome while reducing the healthcare cost. The significance of the NTSV CS rate in the healthcare system: change management is required to reduce the C-section rate, as it is affected by the cultural stigma, hospital policies, personal preference. Other contributing factors could be fear of litigation, inadequate adherence to the evidence-based practice. The healthcare team can implement change by managing the labor room through evidence-based practice, engaging the stakeholders to overthrow the resistance to change, and by developing the culture of continuous quality improvement by improving the maternal and fetal outcome and enhancing the interdisciplinary approach. So while we review the literature, I found some very important and interesting articles, like one of this indications contributing to increasing cesarean delivery rate. Due to the uterine scar, the first CS carries the intrinsic risk of repeat CS in the future pregnancy, justifying the Pragan dictum back in 1960, once a cesarean, always a cesarean. So impact on maternal and neonatal outcome. There are short-term and long-term complications can happen because of the cesarean birth, which include like blood loss, infection, venous thromboembolism. Long-term in the subsequent pregnancies, birth including abnormal placentation and increased hemorrhage and risk of hysterectomy, according to Marshall. So in the NICE care guidelines, aim is to promote vaginal birth in NTSV cases, yet cesarean section remain prevalent, with the CS rate in some hospital exceeding up to 30% in NHS. So what are the factors contributing to the rising CS rate? Like maternal request, CS without medical intervention like advanced maternal age, obesity, deficiency in evidence-based childbirth education, women's informed choices and preferences, inconsistent definition of labor progress, over medicalization of the procedure to avoid litigation and to improve the perinatal outcome, inconsistent practice, growing normalization of cesarean delivery, geographical and cultural differences, and now it become technology-driven childbearing. So what is the background? Where I was working before in Middle East, the cesarean section was 35% in NTSV, and the project was conducted to determine the influence of a set of quality improvement interventions to reduce the CS in NTSV. So what were the aims and objectives of this intervention? Primary goal is to reduce NTSV CS rate in line with national benchmark. Then secondarily, to improve adherence to labor management guidelines, developing induction protocols, criteria for labor dystocia, CTG protocols, to identify and analyze indications for CS in NTSV, to reveal possible areas where clinical practice can be changed by improving the patient care, by improving pain management, one-to-one midwifery care, annual performance for the provider and the staff on best practice, improving the patient expectations by increasing the patient satisfaction, promote shared decision making, and foster interdisciplinary collaboration in maternity care. So quality improvement interventions, which we did to improve this cesarean section rate. Second opinion with justification for all emergency cesarean section in NTSV through the performer, monitor progress and provide regular feedback. Guidelines updated to support labor progression, labor dystocia, induction of labor regarding instrumental delivery, improvements in team communication, implementation of necessary skills, pain management by epidural, including continuous labor support, which is possible by one-to-one midwifery care, feedback, and qualitative initiatives. So in this, my study, the age distribution which patients we include, mostly the predominant group is between 21 to 30 years of age group, and the smallest representation come from the age group over 40 years, suggesting that younger patients are more likely to be part of the study period. So the age distribution of the patient in my data revealed that less than 20 is 3.8% of the patient, 21 to 30, which is the most prevalent group. It is 80% of the patient. 31 to 40 years is 10%, more than 40 is 1.4%. So what is the proportion of the NTSV among the total number of deliveries is 14.8%. And among these, 26.9% underwent cesarean section, while the majority, 73%, delivered vaginally by these intervention. So this CS rate is slightly higher than the national target goal, which is 26.7. So what we achieved is 26, average is 26.9, and suggesting that the institution is performing at a comparable level to a broader national averages. So this is the total number of deliveries. This is the total number of spontaneous and instrumental deliveries. This shows the total number of cesarean section, which include emergency and elective, and this proportion shows the number of total NTSV, which are the primip patients. So out of these NTSV, 73% deliver spontaneously vaginal delivery, spontaneous or induced labor, cesarean section in 26.9%. So among NTSV women, 70% experienced spontaneous labor and 13% underwent induction of instrumental deliveries, and the number of instrumental deliveries were 12%. The mix of delivery method reflects the standard obstetric practice where spontaneous labor is preferred, but the intervention are necessary in some cases to optimize the maternal and fetal outcome. However, the percentage of instrumented deliveries could warrant the review, particularly in relation to the rate of assisted vaginal delivery versus cesarean section. So this is the one instrumental deliveries percentage is 12%, induced labors are 39%, and 70% are the spontaneous labor. So overall, the total number of cesarean section is 32%, and the contribution of NTSV to overall cesarean section is 3.99%. So there is, I will just show you some data snapshot trends of CS rates on monthly basis. So highest CS rates in February, which was 33%, and in December, 30%, and the lowest CS rate in August, 10%, and in September 2022, it was 18%. So most months show CS rate around 23 to 26%, indicating a common range. So if you see, we start implementation of this intervention from November 2021, and when the cesarean section rate was on the higher side, the 35% cesarean section rate was previously we did audit, and in which the cesarean section rate was higher. And from November, we start this quality improvement initiative, and gradually we try to bring the cesarean section rate to 25%. So this is gradually after the intervention from 35%. So the primary reason for emergency CS in this group were fetal distress, which comprise about 45%. Non-progress of labor is 20%. Failed induction is 7.6%. The high rate of fetal distress leading to CS align with the concern for fetal well-being in labor, where abnormal fetal heart rate pattern on CTG, cardiotocography prompt urgent surgical intervention. Monitoring and management strategies for labor progression and induction success should be continuously reviewed to reduce unnecessary CS. So main contributing indication for CS is fetal distress, which you can see it is compromising about 45%. Then is the failure to progress, which is 20%, and then failed induction, which is 7.3%. So what we have done during this study that we checked the cord pH for the babies which proceed in which the moms are proceeded for emergency cesarean section due to fetal distress. So the umbilical artery cord pH used an indicator for fetal well-being was found to be normal 7.25 in 62% of the cases, and borderline in 7.21 to 7.24 in 15%, and abnormal cord pH in 22%. So I will show you this one. So this is the value for the cord pH where it is normal, okay? And this range of cord pH, which is categorized between 7.21 to 7.24, is borderline. And if it is less than or equal to 7.20, it is abnormal cord pH. So mostly no cesarean section which were done for the fetal distress. This is as a part of quality initiative project we did. So we get to know what are our lacks and which areas we can further improve. So this is the area we diagnose that these cesarean cases, which are 62%, and these are the sections done for fetal distress, can be improved. Similarly, the cesarean section, which are borderline, is 15 to 16%, and the cesarean section, which are 22% compromise and the less with abnormal cord pH. So we try to focus on this area, which is done for emergency cesarean section but the cord pH came to be normal. So we can see in these cases, in this part of patients, in which we can give more time to the patients. So other method, intervention we did is the peer review process aim to improve the quality of care and keep any practice that do not meet the evidence-based practice. Assessment on monthly basis to find out the triggers for improvement or deviation from the standard. So this is the performa for the peer review checklist and NTSV CS. So in this performa, another MRP or the consultant will sign and review the case that this section was done on a ground or on basis that is indicated. So it will evaluate the CTG protocol was followed, the labor protocol was followed or not, indication for cesarean section was what, epidural was given to the patient, what pain management was done, and what was the pain score and what analgesia was provided, any complication during the procedure. So this performa is filled to evaluate, and then feedback was given to the operator or to the provider care. So what are the barriers for reducing cesarean section? Labor and delivery unit culture, clinician attitudes lead to defensive CS, fear of litigation, maternal preference, growing normalization of cesarean delivery, geographical and cultural differences, technology-driven childbearing, inconsistent practice across the hospitals. So what ACOG, American College of Obstetrician and Gynecologists, recommend for safe prevention? It recommends that cervical dilatation of 6 cm be considered as the start of the active phase of labor, and it suggests that active phase arrest of labor to be defined as no progression in the cervical dilatation for the patient who are at least 6 cm dilated with rupture membrane despite 4 hours of adequate uterine contractions or 6 hours of uterine activity with oxytocin augmentation. If we have these two parameters and there is no progress, then we should label the patients as failure to progress. So recommended that prolonged second stage of labor be defined more than 3 hours for pushing in nulliparous patient. Arrest in the second stage can be identified early if there is lack of fetal rotation or head descent despite of adequate contraction, pushings, and the time. Either low dose or high dose oxytocin strategies are reasonable approaches to active management of labor to reduce operative deliveries. Suggest management for operative vaginal delivery before performing cesarean delivery for second stage arrest. For most low risk pregnancies, cesarean delivery appears to be pose greater risk for maternal morbidity and mortality than vaginal delivery, and labor dystocia is the predominant driver for this intervention. An individualized approach should be used to diagnose second stage arrest, incorporating information regarding the progress, clinical factors that may affect the likelihood of vaginal delivery, and discussion of the risk and benefits of available interventions. And individual patient preference is recommended when time in the second stage is extended beyond these parameters. So in conclusion, the literature review regarding different quality improvement projects to reduce effective CS rate in NTST low risk population suggested evidence-based practice, care bundle that address labor dystocia, promoting institutional guidelines and auditing data and feedback. In the future, telemedicine and digital health platforms could support better labor management by offering real-time consultations, second opinion, helping to avoid unnecessary cesarean sections. Additionally, the development of artificial intelligence tools that predict labor progression and identify women at risk of complication could support more tailored care and reduce the likelihood of cesarean delivery. So, what we should focus? We should focus on prevention When women have a C-section in the first labor, an estimated 90% of all later births will be C-section. Although C-section can be life-saving intervention for mom and for the neonate, it can also lead to short-term and long-term health consequences. So greater understanding of how the mode of birth can affect long-term health outcome for the mom and the neonate is crucial to informed decision making done by the woman and the policymaker considered the very different circumstances and varied risk between low resource and high resource setting. So these are my references, especially from the WHO, ACOG, and NICE guidelines. Thank you. Hope you enjoy the presentation. If you have any question, you are more than welcome.
Thank you so much, Dr. Shahila, for the presentation. So any questions?
Can you see my screen?
No, it is not visible, doctor. Please share your screen.
Yes, I share, but I sent you a request about that. Could you accept?
We gave you the access, doctor.
Can you see my screen now?
No, not yet. You have the access, doctor. Please proceed with the PPT sharing. Dr. Sophia, are you facing any difficulty?
Yeah. Could I will be next?
Could you please send me the PowerPoint slides so that I could share on your behalf?
Okay, I will try.
Okay, doctor, please.
In the chat?
If that is possible. I think the attachment option is not enabled. Please email me your slides, doctor.
Can you see my screen? No?
Yes, we can. Perfect.
Okay. Can you see my slides?
Yes, perfect.
Okay, nice. Sorry for that. Can you see whole screen, right?
Yes, please proceed.
Thank you. And their androgen receptors mediated signal pathway play significant role in the progression and treatment of ovarian cancer. And this meeting, your home, is such an appropriate teamer, and again, the ovarian cancer, so many of us. I will always tell my patient when I meet them that you specialized in that is very appropriate, and now more than ever. We have so much more to be hopeful about given the changes in the landscape, research understanding of ovarian cancer, and how to treat it so that we can realize the promises of prevention of oral cancer survival, who diagnosed a lot of clinical trials. And I know that there are simple speakers that will be touching up on this in the conference, but this has been a decade of radical gynecology cancer advanced with more than 50 clinical trials. In the majority of them have been in the ovarian cancer space, and these are phase 3 trials to larger trials where we study standard of care treatment and compare them to standard plus experimental therapies that really changed our understanding of how to treat this disease and really move the needle. And the great news in the ovarian cancer therapies are improved. And today we know that the ovarian cancer is the particular epithelial ovarian carcinoma is the most dangerous cancer. And the reason of that when we try to treat the ovarian cancer, especially ovarian carcinoma, it will be resistance because of the androgen receptors. And androgen receptors is implicated in several cellular processes, proliferations, migrations, and invasion of cancer cells. And the main idea why we have resistance to treat ovarian cancer, it is the stimulus and epithelial mesenchymal transmission. Despite the potential clinical trials with anti-androgen have shown limited results. However, experimental studies suggest that targeted androgen receptor may suppress disease progression, underscoring the complexity of androgen receptor mediated pathway in ovarian cancer treatment. And today, ovarian cancer is the highly lethal gynecological malignancy, often diagnosed at advanced stages due to non-specific symptoms. Despite advancement in treatment, the prognosis remains poor due to development of chemioresistance. Their key facts, it is they're characterized by high mortality and late-stage diagnosis, and platinum-based chemotherapy is their cornerstones of treatment development of chemioresistance, insignificant challenge. Chemotherapy, a better understanding of the molecular meaning, its biology, what are the potential and genes that really drive development that we can potentially harness our knowledge about the disease, is snowballing and evolution that we talk about improve quality of life. This is a greater slide, and I am sorry that there I should be a little bit bigger, and I'm sorry it looks so small here, but this is basically a timeline of over 70 years of Food and Drug Administration chemotherapy drugs approval in ovarian cancer. Want you to notice that on the slide of this timeline, we only had like 10 drugs approved during that, but forward now to 2005 to 2024, they list 20 years, incredible numbers of trials and successful positive trials that have led to proven new treatment, and we have had more than 16 approval in the last decade. A couple of those have been attracted since, but you can see just exponential improvement in the number of drugs we are giving patients that are approved. How? And that's because the science has expanded. The funding research has expanded. We are doing more clinical trials, truly understanding their disease. And this is a slide I just don't like very much, but still, because of this old school survival patients, based on they so boring. If you had, I see about 30 of women beyond 5 years, and this is very fortunately old news. We see studies the year observed survival for cancer is on the rise that has been happening over the last 40 years. You can see there again in 1975, the overall 5-year survival rate was only about third of patients 5 years, improved by 10%. 2015 to improve today, and this is actually much higher for many. And on this slide, we can see that their progress, which I have already explained, and we continue to move. The needle of this is not enough. We need every single woman for their foundation. This is a great study that showed from 1975 to 2005 this year, advanced chemotherapies and surgery for chemotherapy really improved. Overall survival for all women with advanced stage disease, and of course, an important work was done by many individuals, including Julia Roberts Armstrong, so many other who have his disease, for many new doctors, Davidson for cancer. I want to focus on look forward future here. We still have about 20,000 women in the US who receive a new diagnosis of a cancer, and unfortunately, almost 13,000. I really want to hurt you fragrance that your women are dying of cancer, and death decreased by 40% treatment surgery tailor treatment. Somewhere we're gonna talk about that one size all paradigm not being sick anymore. We have to do precise and individualized treatment for as well as the women are being diagnosed with cancer. The 1990s increased 10 years 3%, and we think this is likely due to more use of oral contraceptive, a little bit less menopause, hormone therapy, also talk a lot, which is a medical term of why that potential reduction rate organization. We focus on promotion advanced in a multi-white paper 13. What is the best treatment of the best testing that we can do? The best survival care, survivorship care we can give our patient with the cancer. You can see some little examples here of white paper that we published recently on screening, on surveillance, on how do genetic testing and should get genetic testing versus tumor testing on inhibitor maintains therapy, published about 1 year on one of our biggest prioritized of organization in these other doctors and nurse and individuals who care with very cancer. What is the state of their science we have right now, their best critical trials to guide us, and how I should treat my patient and my community is in this kind of helps kind of playing field standardized. And the next generation of cancer researcher is something that is tremendous as well. So really role modeling on all levels. We do ton of policy advocacy. We do on Hill. We go to the Hill and talk to our congression partners. There we talk to the FDA, the National Cancer Institute, to make sure our voice are heard. So we do this and partner with our wonderful patient navigate kids, because frankly, congression folk, congressmen and women, senator wanna hear from patient, that they want to hear from people like me. So it's really nice to go together and give the patient perspective as well as the medical and scientific perspective about what we need to be more successful and helping our patients. We are also promoting groundbreaking science in our annual meeting every March this year, 14th to 17th in Seattle. We'd love to see you all there. We have a beach now. The kids are welcome, and I think we had over 304 meetings last year. We love partnering with wonderful organizations, like we are going to have more impact on the field with partnership, and one of my president. This is my presidential this year, multiply impact, and you can see within the word is really important, because it really takes a village and multidisciplinary community-based approach to improve outcomes and eradicate. And so by building focus on building extraordinary medical and science career, by building the best cancer programming and all parts of the country, not just the cancer centers, but is suburban, and focusing on community and how we come together with community stakeholder. And during these extraordinary times, we live in the biggest impact. And love this quote for one of our college, Cynthia Lisa Wally, who is a nurse at the National NRG Oncology, one of our cooperative group where we perform clinical trials. And as we commit to research for funding, commitment to participate, and commitment for researchers working together makes the difference. And this is so true. And so support organization CRA really help us get there, because that is where you have the centralized support, and then the stakeholders relationship develop from here to really bring the best people together in science and industry and government in the community, and from the patient side as well, to make difference. And one of the way we do that as the GEO program called the Bridges Research Initiative, partnership with Oncology Foundation, which is one of the largest clinical trials network in the world, making a real difference for our patients as well as with the foundation. Cancer Foundation and huge partners. This is basically the next generation of trials who lead ovarian cancer trial, and Dr. Adams from New Mexico clinically this program. And I know that there is a separate talk about this Dr. Adams put together, and think it's available on the demand. I would really encourage you to watch it. Inspiring to see. I just want you to know how that we are, and that is next generation of physicians and scientists is so dedicated to the mission of improving patients. And in fact, that was our first port over 30 very talented scholars, and more than 65% of the trials were developed. And these first ovarian cancer trials have really focused on the OCA, ovarian cancer I have already mentioned that foundation of this big group from the national in the GG that help us with the really big hundreds of international trials that can change standards of this is where inhibitor trials were so many other important trials that were doing in their ovarian cancer, but it takes funding to do grid and move forward. And so there is number of different ways that research, this is one of the things we must advocate for HEAL in the department of one of the greatest supporters of the federal government research. And this is something foundation advocate for more than a decade in 2008. They have this program called Ovarian Cancer Research Academies, and in 2008 they funded us $10 million a year for that to think, my God, that's right, to be able to come up better treatment. And you are right, and it was enough, and we all kept advocating, and by the next year it was double, and then by 2024 it was more than double again, $45 million. We are not satisfied with that coming out of some of the current scholar in the American Cancer Academy are some of the brightest minds in the field. There are PhD or DR PhD who either run clinical trials or do science in the lab, and some of these are just wonderful colleagues, and oncology are really dedicated. I am thrilled that Dr. Adams and I just see there is a brand new mechanism called the Clinical Academy Wars, and this is to train the next generation of clinicians or people who do clinical science and trials. The other academy I showed you was for what they call lab science, our translation science that helps those discoveries that we then take to the clinical and study in humans and eventually in the specific population like cancer survivals. And so we are leading this new, there are here and going to invite the first group of scholars to join us in 2025, and we are going to be building those bridges and trying to multiply our impact some with you knowing. I'm going to go back and a couple times with the Cancer Academy and bring the scientists from the lab together with the clinician and the hospitals so we can really accelerate our impact together. I just cannot say good things, really tens of millions of dollars and promising research and really involve fun, innovative research, groundbreaking stuff that high risk care reward as our foundation of the foundation, and so third federal and government foundation grants. This is how we move the needle. However, on the site, the National Institute is absolute wonderful. Unfortunately, we have seen in a decrease in funding and number of trials in ovarian cancer. Another GI cancer are the last due to the need for consolidation groups. And so we really have a lot of work to do here. And this is one of my colleagues, Ryan, from the university, and he wrote, and the funding to live measures for National Cancer Institute funding that means that amount of funding a research area receive according to how lethal they is or how much of it negative impact a population. And the three he found in his work with the highest lethality ratio: breast, prostate, melanoma, incredibly important cancer support. However, they lethality score, even though they won 123 in funding, where 12, 17, and 16 among all cancer. Meanwhile, uterus and cervix range, and 13 funding, but we are 13 in terms of letalities, or really seems like it's little backwards here, and this is really important thing. You can also advocate with your congressional partners, continue. This is a huge advocacy fight we have right now going on in terms of increasing that funding for the patient who need the most, so that we can really flip the switch on out there. We just had our annual, we have a virtual in-person session that we do on how we just had our virtual session this Monday, and we had almost 50 members and patients together representing 26 state to 77 congressional. We met about all of these things that we were talking about. This is some of my colleagues here doing that on Wednesday. And a couple months ago, I went in person and banged on several doors that had some great meetings with several of our senators and congressional people in their staff to talk a lot about funding for ovarian cancer research, as well as chemotherapy drugs that right now one of the things I'm very passionate about, continues to be passionate about, that we have enough essential medicine for our patients, so that you have enough to worry about without having to worry about drug shortage or supple shortage. That crazy. And as you may know, in 2023, we had one of the worst chemotherapy in history. And so recently on September 8, we had National Central Shortness Day, and how many congressional meetings about it, because all the things are much better. Now we still have a long way to go, and where we are very avidly asking, then thank you to who's doing this as well. Have a Congress legislation to prevent chemotherapy shortage, authorizing the FDA to have more authority over regular regulation of manufacturers, meeting the bill, providing incentive to manufacturers in hospital quality products, and also working with the FDA. We also met with them to talk about National Institute of the largest of, or one of the most prestigious institution in the world, is for the national and most exciting and modern times. So we really want to make sure we are continuing to support and make sure they get the funding you need, so we can have the trials in their science in our chemotherapy. Village Hopkins, John Hopkins, the problem with some of the reason that continue that older genetic drugs are very cheap to manufacture. They are almost all manufacturers over, and return on investment for the manufacturers of these few companies are investing in doing this. So consolidated makes market issue happen. Unfortunately, a lot of them have been resolved, and as you that the drug that you need right now to treat ovarian cancer are available, but this is only be improved in the short term. So we are really advocating for long-term solution, and continuing to advocate for in one of the ways that is working with the make sure all of the important drugs put on the FDA essential medicine drugs, the pandemic, to make sure that there was emergency access to vaccines and other drugs that are needed commonly, antibiotics and things like that. But believe it or not, there is no modern chemo on this, and there are some of the most life-saving. These are drugs that help cure and save lives, and so we are working really close as well as a number. And we talked about chemotherapy, I guess. I'm in cases, and certainly some ovarian cancer chemotherapy, really great article of the New York Times 3 years ago, and I have a link here if you wanted to check it out. But I was basically a growing cancer patient, especially with lung and prostate cancer and melanoma treatment and options. And the reason for that is we are learning a lot more about what this tumor response to some ovarian cancer is responsive to chemotherapy, like high-grade cancer is going to be really responsive in cases, especially growing tumor. And we are also learning about their mutations, their DNA, basically errors in the DNA makeup themselves and molecular profile, their height and potential basically grows. And how we can shut those genes down or block them or alter them in some way in order to get an upper hand on the cancer. And some cancer are much more growing food cancer, granulosis cancer, low-grade endometrial cancer. There are relatively growth patterns with very low activity. They don't replicate or dive themselves into more cell very quickly and much more likely to express certain potential in genes as well as hormone protectors like stretch and progesterone, which are the two most important hormones ovarians that either we can potentially leverage and advancement and molecular medicine precision medicine so much more about ovarian cancer. We have learned more about hereditary syndrome. Well, women with genetics, there is over 25 different, genes identified, and there are more that are associated with a cancer, with breast cancer. They are predictive markers and tumors that we can now perform something sequence and study to understand that are the molecular alteration and tumors that we can target with drugs. And potentially, we are circulating DNA taken blood test to find. I am not the tourist, but genetic make the DNA fragment with the clinical shot of together and marker discovery and genetic markers and molecular profiling of our patient tumor. We can earlier with treatment that are more likely to be successful and patient, we can realize their promises more personalized medicine and accelerate this novel treatment approach more of patient. And so as we think about for sure, it's super old news that one size fits all strategy where everyone should just attack out, is just not the info anymore. We have learned so much more about this in the last 15 years with precision-based mold treatment. This is a vibe. This is a vibe that is here to stay and is, I think, one of the number of things that happen us really improve survival and better and even better quality of life in our patient. Let's get back to that question of cancer without chemotherapy, given our breast cancer in their last 25 years evolution breast cancer treatment National Institute and other national guidelines here go around chemotherapy for the majority of patients with high risk of advanced stage breast cancer. But after getting to understand the molecular basic of the disease and the development of treatments, so target those molecular markers, we create system to which patient would respond better to which type of treatment. And it really began a shift in the treatment pattern. Normally, patient with breast cancer says you may have hormone receptor, and now is more work to give secret hormonal therapy, and therapy a receptor chemotherapy patient like androgen receptor patient, and that has revolution that we are doing the same think in ovarian cancer to same therapy that have been much longer in breast cancer patient literature and study them in our patient population. And we are doing that because there is a table of women with hybrid ovarian cancer, the most common type of cancer, and as well as low-grade cancer. And you can see from this from the slides, there is a lot of differences here in terms of a typical cell under the microscope. Quickly they replicate what mutations, so that in order their best. I am great girl, Dr. David Gerson, and I have been working Dr. David Gerson and I have been working together, and I have been working together, and is one of the financial incredible pioneer of the space and survival studies together, looking at different members like low grades. And we know that, a really strong upfront surgery where we try to get all the diseases out is very important in these patients. They don't respond as well to chemotherapies, and we have learned that if you, for therapy commonly used to chemotherapy treatment after surgery, you give it after chemo and surgery, or you just by itself after surgery may do a lot better than just the car salty. Right now, to a large international clinical trial in the world was newly diagnosed for low-grade cancer, where we have trying to study, do you get email in chemo important? Here is the question: you give chemo followed by the treatment, or can you just do the treatment after surgery, just like we do in the cancer where they have moved away from chemo or chemotherapy? And this is one of the trials in development, does not have all in one of their treatments. It's a big step. We're all 86 of our patients to be able to give patients an answer about treatment for our in the same way. We are looking at in this endocrine like something TDK 46 inhibitors that help regulate cell growth, and the breast cancer, they were much more effective than just doing the endocrine therapy like blood by itself. This has been studied in the Anderson Cancer Center in Women with Cancer studied, and others really understand if you combine hormone therapy with inhibitor, even for surgery, when patients have really a lot of tumor in difficult to do surgery, we see. And then the small pilot towel, they did not give any patient TAX 60% response rate, and patient before they went for their surgery, and one of those patients had complete surgery. It was remarkable, and the other 40% had a stable disease. The disease did not get worse during that time, and so that resulted in about 100% for all those patients. So they are now trying to expand this travelers to seem like we eliminate chemotherapy altogether, and patient better outcome and great quality of life. One way to study of cancer there, especially rare cancer, is by doing for basket for instead of just setting one type of ovarian cancer and one drug or two drugs and comparing in one another, have multiple different type of ovarian cancer being, and your thermal molecular profile look like, what does mutation looks like there, like 11 to 12 different treatment options that a patient can enroll. And this is efficient way to study new treatments and to make sure that we will realize the precision medicine, getting the right treatment for the right patient and right time. And so this is called the trial. I love this name and Jubilee Brown, Bachi US leaders listed on the site. This is open at many different centers across the country yards. So we are very excited to see the result of this trial. So one of the most exciting new types of drugs that have really become involved in the last 5 years basically have 3 components. They have an antibody and then drug, a highly selective monoclonal antibody that will attach to a very specific and with less, and then it's attached to design to introduce into their cell, and then there help that chemotherapy drug into target cell. And one of the most interesting and exciting cancer that you may have heard of, it's here or text survives, and this is for patient who have full center positive platinum resistant apathy are full of repairing cancer. This is one of the first that was approved in the modern era for patients with platinum-resistant disease, and there are huge need for more in this space. And this is where they come drug that was given every 3 weeks to physicians' choice chemo, and so things like TAX or given both for kids time, the tumor did not progress or get worse, called progression-free survival, and the ovarian survival were all significantly better in the patient with team with the TAX. So this patient had at least 75 expressions of fully receptor alpha and there's silvers, and so it's really important to get molecular testing on for your tumor. They do it early and often because tumor can change and take, and then can really help drive the best treatment for patients. Another really wonderful example of an is called trust to direct to, and some so this is it also known as in here too, and these are results from the Destiny Pen to study, which again, this was one of those trials where you have multiple tumors in test. In this case, they were being tested with one drug, this drug and this for patient who had that expressed that HER2 promoter talking about earlier, that common patient with breast cancer and some cancer and ovarian cancer, and when the tumor expressed their medium amount of high amount of potential, they were eligible for this trial and this and have this body drug. I can see about patient with ovarian cancer were enrolled, and it was pretty exciting data. So for patient who are high expressed of her protein, almost 65% of patients had excellent responsive, with several of them having a complete response. That tumor melted away, was a partial response, but even though who did not respond, 35% had stable disease. So basically, again, it halted the tumor for several months or more. That can be a win-win. Any of these responses were durable, meaning they lasted quite some time, and so very excited about this is being studied further in ovarian cancer. But this, getting tested for her to is another opportunity for patients who may have had a lot of other treatments to get that right size treatment and the right time. I'm gonna add a little bit hereditary cancer, genetic, and they're injected to me removal of full of hangout. With prevention, we used an oncologist like we live to help our life. That's what we do. It's even more excited when we can help together, and I know that you all understand that, and there is been such a revolution only molecular testing and hereditary genetic testing from the early 1900 and 1960, when Dr. Henry Lynch first identified some that were responsible modern era in the 19 and now we have so many mutations that we identified, and what is the really good about what now it is not just about knowing what your risk is for cancer. We know I have emergence for targeted and directed therapies for patients who have some of these markers earlier genetically. They inherit them, or the tumor express some of these markers, and some of those include carpers. I know there is a couple of other speakers who are going to be talking about PAT inhibitor. I'm not gonna go into this too much, but inhibitor have revolutions how we treat over cancer in, especially upfront with those patients expressing either their bracket as a hereditary marker or in the tumor, or something called HR, the homologous for combination deficiency really benefiting from life. We have to be careful how long we use inhibitors, like many of the chemotherapies in target side effects. So usually recommended continuing them for 2 years as long as patient is fitting them. I love it. Sometimes we get the opportunity to go in together with CRR on consensus statement, or to enter statement that other may include in the OCA. And this is a really important statement about ovarian cancer screening and symptoms awareness, and just truly the reality that unfortunately, although we have had such a huge focus on screening of brain cancer, it's very difficult to disease because there are no symptoms of disease and cases, and they're really of right down to find this cancer site since they are very invasive. And each since it's not like a mammogram where the word or pap smear and the organ is become more elusive. And so there's been a huge interest in research, including some of my own wonderful colleagues, that John Hopkins, and I'll introduce him on understanding, leveraging or basic understanding of ovarian cancer, and was called a tubal hypothesis. Now that the majority of the ovarian cancerous are actually seeded from cancer cells from the fallopian. Most cancer may not be ovarian fallopian to help prevent cancer. I think one of our greatest assets we have in the previous space, and so we know that 20% of cancer occurs a genetic mutation is really important for all women and men. Women who know the risk because men can also pass along the bracket, and women who their daughters and son, their daughters. So there is lots of cancer that know that awareness need to be made about that. What I want to say about their flu tube theory is that we think about 70% of the most common and lethal ovarian cancer begin in the fallopian tubes and research. What I want to say that function impact of patients who have the ovarian versus the tubes removed, because quality of life is important, and we needed to understand, is there a benefit there? And what she found in her, she did this with the University of Washington, and women who had their tubes only removed were less likely to go into menopause, less likely to have problems with sex, there are fewer problems with cognitive function, and this menopause of all of the menopause symptoms of women, there was significantly high risk of severe menopause symptoms and lower column leave of life and patients. Instead of I'm not the trial which is ongoing right now, which is an international. And next, integrated And what I want to say that it is very nice that we try to collect and try to help each other in our trials. And thank you everybody for this session and for this congress. And if someone have any of questions, I am very grateful to answer.
We are going to talk about egg donation, egg donors, receptors, treatment results, and the risk of the treatments. Currently, many women decide to postpone motherhood for economic, personal, or professional reasons. Many women under 35 years old do not want to be mothers and have other goals like studies, work, and travel. So, in our fertility consultations, we see women over 35 years old and 40 years old in whom the quantity and quality of eggs are often no longer sufficient to be mothers with their own eggs. This leads many couples to decide to undergo fertility treatments with donated eggs. Donation is an assisted reproduction technique in which donated eggs are used to fertilize them with a sperm from the couple or a donor in embryology laboratory. The embryos that develop will be transferred to a woman whose eggs do not reproduce. They were given to be used for assisted reproduction treatment, but she will carry the entire pregnancy and become the legal mother. Unfortunately, fertility in women decreases as the years go by. The eggs decrease as the year. Approximately 1 million eggs when we born, 30,000 when we start menstruations, and the optimal fertility occurs between 20 and 30 years old. After the age of 35, fertility begins to decrease. There is an abrupt decrease in the quantity and quality of eggs, and it difficult to that the woman could be pregnant. In this graph, we can see how does woman age influence fertility. As we get older, our probability of achieving a spontaneous pregnancy decrease. You see that the decrease becomes marked after the age of 35 on average. So in this graphic, you can see that 35 years and the decrease of pregnancy. Regarding the laws surrounding fertility treatments with donated eggs, there is a variation between countries. For example, in Spain, donation is anonymous. In Germany, it is prohibited. And in Peru, it's not legislated. Treatments with donated eggs represent 32 of all in vitro fertilization treatments in Europe, 18 in Latin America, 23 in Peru, and in Mater Clinic, it represents the 25%. Now, let's talk about the donor. The requirements that donors have meet are between 20 and 35 years old. In Immature Clinic, the requirement is to be under 25 years old. They be in good health and have no personal or family history of hereditary disease. They also have to have a psychological evaluations. It is important that they have to understand very well about the risk of the procedure and are sure of their decisions. To evaluate physical health, they undergo a general evaluation, a blood test that also evaluates sexually transmitted disease and drug use. The ovarian stimulation process lasts on average 10 to 12 days. Donors use hormones for the development of the maximum number of eggs. During egg aspiration, there is a risk of bleeding, and post-aspiration, the greater risk is hyperstimulation syndrome. Both complications are currently rare. It is important to know that a donation can be known donor or anonymous. The recommendation is to be anonymous. In Immature Clinic, we do that in that way. It is recommended that each donor make a maximum of 6 donations. Now, let's talk about the recipient or receptors. She is the one who will carry the pregnancy. The studies that are carried out of her are blood tests that evaluate that she is in optimal condition for pregnancy and also rule out sexually transmitted disease. Exams to evaluate uterus and cavity. Transvaginal ultrasound and office hysteroscopy are the best tests. Regarding how the uterus is prepared to receive an embryo, there are mainly 3 schemes. The first is the modified natural cycle, where the natural cycle is followed, and when there is an adequate amount of endometrial ovulation is induced to schedule the embryo transfer. The second is the artificial, where the recipient takes estrogen pills to make the endometrium grow. When it has an adequate thickness, the transfer is scheduled and progesterone is added. And the last is the modified cycle, in which hormones are used in low doses to grow a follicle and therefore the endometrium. When the endometrium has an adequate thickness, ovulation is induced and the transfer is scheduled. The 3 types have the same objective: to obtain the best endometrium to transfer. And we can see in this picture the best endometrium to transfer. Embryo transfer is a procedure that is performed without anesthesia. The room where it is performed is next to the embryology laboratory, so that the transfer for the embryo is quick. Regarding the results of the treatment, it is important to know that if we compare the results in women over 40 years of age who undergo reproduction treatments with their own and donated eggs, there is a greater chance of pregnancy with donated eggs. In this graph, you can see the difference in the pregnant rate between patients who undergo in vitro fertilization with their own and donated eggs between 1997 and 2018. In this line, orange line, it is donated eggs, and the green is the own eggs. The green and the blue. In this graph, we can see that the treatment rate, success rate according to the age in reproduction cycles with own and donated eggs. We are going to take the group of 40 to 42 years old, where the pregnancy rate with own eggs was 15%, and we compare it with the donated eggs, it was 35%. So you can see the difference between the probability to pregnant in the group of donated eggs compared to the own eggs. And it is important to remember about the age of the patient. It must also be considered that the paternal age influences the pregnancy rate. Sperm quality begins to decrease after the age of 45. What risk do treatment with donated eggs have on the recipient or receptor? Increased risk of severe acute maternal morbidity that includes maternal death, postpartum hemorrhage, preeclampsia, HELLP syndrome, pulmonary embolism, admission to intensive care unit, and severe psychiatric disorder. That's why this group of women represent a high risk in pregnancy. Studies have been carried out on the children of these patients, and it has not been seen that they are psychologically affected. Thank you for your time.
Thank you so much, Dr. Pilar, for the presentation. So any question from the audience side?
Any class of organic complexes that are difficult to dissolve in water but are soluble in organic solvents. Lipid metabolism undergoes a few physiological changes during pregnancy, which are necessary for health, fetal development, but result in alterations in lipid levels. Triglyceride, on the other hand, increase by a factor of more than 3 from 12 weeks of gestation to the end of the third trimester to support energy storage in the mother and promote embryonic development. Triglycerides below 1.7 millivolts per liter are considered normal. In the last few weeks of pregnancy, however, it is possible that the triglyceride level to surpass 11.3, which is considered severe hypertriglyceridemia. Severe hypertriglyceridemia during pregnancy can result in many complications, including acute pancreatitis, hyperviscosity syndrome, preeclampsia, macrosomia, premature birth, and fetal mortality. Acute pancreatitis is an uncommon yet potentially fatal condition that affects both the mother and the neonate. Its incidence is estimated to be between 3 and 10 per 10,000 live births. In contrast to other etiologies, acute pancreatitis induced by hypertriglyceridemia during pregnancy exhibits a higher propensity for severe manifestation, which correlates with an unfavorable prognosis and augments both maternal and neonatal mortality. This case report will focus on the management of hypertriglyceridemia during pregnancy in the context of a pregnant woman who developed an acute pancreatitis complicated hypertriglyceridemia in our hospital. So our patient was a 32-year-old Indian woman, gravida 3, para 2, previous 2 C-sections, presented at the at gestational age of 24 plus 3 in November of 2022, complaining of severe epigastric pain radiating to her back. Her previous pregnancy was terminated at 32 weeks of gestation by emergency CS in 2019 due to acute pancreatitis secondary to hypertriglyceridemia. She was admitted to the ICU at that time due to tachypnea and tachycardia and was started on insulin infusion. And then the decision to terminate was taken in view of her unstable condition. She was switched to oral medications after delivery. The patient had no other relevant medical history. She had a normal TG levels outside pregnancy. Her family health history was irrelevant, and she had no clinical stigmata associated with hypertriglyceridemia on physical examination. Was non-alcoholic nor a smoker. Her labs showed a high lipase with the upper normal range of 53. Her lipase was measured at 268. Amylase was measured at 270 with the upper limit of 180. Triglycerides was measured at 49 with the upper limit, as mentioned earlier, at 1.7. So all indicate elevation in lipase, amylase, cholesterol, and triglycerides with the total cholesterol HDL ratio also elevated, as well as CRP. Abdominal ultrasound was done, and which showed diffusely enlarged pancreas, more at the tail with irregular surface and surrounding peripancreatic free fluid, suggesting of acute pancreatitis. Minimally dilated intrahepatic biliary radicals with a normal diameter of CBD, enlarged fatty liver, and no evidence of gallstones were appreciated. Mild acidic free fluid in the abdomen and viable intrauterine fetus was appreciated. She was initially kept NPO and was started on a normal saline, 150 mL per hour, insulin infusion at 0.1 units per kg per hour, and dextrose 80 mL, D5 80 mL with monitoring of her random blood sugar hourly with adjustments accordingly. Also, she received omeprazole, meropenem, Clexane as DVT prophylaxis, iron, vitamin supplements, and analgesics when needed. After initial conservative management failed, the patient was admitted to the ICU and underwent plasmapheresis after insertion of a VASCAT with 3,000 mL of albumin, 5% as a replacement fluid, and oral calcium. Following that, her TG improved from 49.1 to 5.1 millimoles per liter due to plasmapheresis, insulin, and being NPO. On day 2, she was started on omicron, which is an omega-3, 2 grams orally twice daily to maintain her TG levels below 5.6. once she started feeding orally. On day 3, she was started on a low-carb and low-fat diet. On day 4, her TG levels exhibited a trend toward 4.3 millimoles, and her central line was removed. On repeating labs, her TG levels raised back to 14.3, so she was started on fenofibrate, 145 mgs once daily. The following day, her TG levels were elevated to 16.4, even though she was on fenofibrate. So she was started on Lipitor, 40 mgs once daily. Her TG levels then were stabilized after her condition improved, so she was discharged on this regimen at 25 weeks with regular follow-ups and labs in endocrine and obstetric clinics. The patient presented to the obstetric and gynecology emergency room at 36 weeks with complaints of lower abdominal pain, back pain, and leg pain. Her CTG showed fetal tachycardia with a heart rate of 170 to 180 beats per minute. Therefore, she was taken for category 1 CS in view of fetal distress, which was uneventful. She was discharged in stable condition and kept on a home regimen of Lipitor 40 mgs, fenofibrate 145 mgs, and kept on omega 3 2 tablets daily. The patient was advised to take Clexane for 10 days, Clexane injections for 10 days, recommended lifestyle modifications to maintain a low salt and low fat diet, and to exercise as tolerated. She was given a 6-week follow-up in the gynecology clinic, but failed to attend the appointment and subsequently did not counteract or recontact to reschedule. So hypertriglyceridemia in pregnancy is the third most prevalent cause of AP, accounting for up to 14.4%. Other causes include gallstones and alcohol consumption, comprising 65% and 5 to 10% of the cases respectively. Hypertriglyceridemia can manifest in 2 ways, primarily as in the case of congenital chylomicronemia syndrome, which causes a severe deficiency in apoproteins C2 or lipoprotein lipase, or secondary to metabolic syndrome, obesity, undiagnosed or uncontrolled diabetes mellitus, alcohol consumption, and drug use, including tamoxifen, steroids, diuretics, beta blockers, and atypical antipsychotics, or even the absence of any predisposing factors. During pregnancy, the estrogen causes change in lipid metabolism to provide adequate nutrition to the fetus. Some women with genetic predisposition or an additional triggering condition may experience severe gestational hypertriglyceridemia. It can lead to numerous life-threatening consequences such as AP. There is still a lack of clarity of the pathophysiology mechanism of AP caused by hypertriglyceridemia. One theory suggests that TG-rich lipoproteins stimulate the lipolysis, leading to elevated levels of free fatty acids. This, in return, can cause damage to the acinar cells and vascular endothelium of the pancreas. Moreover, in the lab investigations, it was discovered that the fatty acids cause damage to mitochondria as a result of high levels of TG in the blood. The ischemia-induced acidic environment exacerbates the toxicity of free fatty acids, leading to heightened pancreatic damage. The International Association of Pancreatology and the American Pancreatic Association have stipulated that the diagnosis of acute pancreatitis requires the fulfillment of at least 2 of the 3 specified criteria, including clinical symptoms of upper abdominal discomfort, lab findings of serum amylase or lipase levels above 3 times the upper limits of normal, and indicative imaging suggesting AP, as in our case. In reference to our case, our patient fulfilled 3 requirements of the diagnosis of AP. treating severe gestational hypertriglyceridemia is a complicated process. Due to its rarity, there's currently no documented guidelines available for managing this illness. An interdisciplinary strategy is required involving collaboration amongst obstetrics, endocrinology, metabolic medicine, and dietitians, hematology, and gastroenterology as well. This is acknowledged as the cornerstone of the effective management. The prompt diet, use of nutritional supplements are crucial for keeping TG levels within the normal range. Patients should be instructed to have a diet that is both isocaloric and low in fat, with less than 20% of the total calories derived from fat. Omega-3 fatty acids, which consist of both ketonic acid and docosahexaenoic acid, are widely regarded as the fundamental component of the nutritional supplement. The compounds decrease hepatic lipogenesis and promote fatty acid oxidation in the liver and skeletal muscle. There has been studies that showed a decrease in TG levels by 25 to 30% following the commencement of this treatment. In cases of severe hypertriglyceridemia not controlled by diet and nutrition supplements, like initially in our case, patients may require hospitalization to be kept NPO, started with IV fluids, dextrose 5%, and insulin optimization to their TG levels. There are currently no guidelines for hypertriglyceridemia drugs prescribed during pregnancy, and most treatments are based on the case reports with variable degrees of success, which include statins, niacin, and fibrates. Although statins studies are disputed, statins use among pregnant women is restricted because there may be some potential teratogenic consequences. Niacin is considered in pregnancy as a category C, which has been shown to boost HDL levels while decreasing LDL levels. However, its use is restricted due to its significant side effects, which include hot flushes, GI upset, and potentially liver damage. During pregnancy, fenofibrate is classified as a category C, although some case reports indicate that it was safe to be used during pregnancy. This medication lowers plasma TG levels by 50%, which include while increasing HDL cholesterol by 20%. It also reduces the very low LDL secretion and increases plasma TG lipolysis. Another treatment modality that has been suggested is IV heparin. It functions through the activation of lipoprotein lipase. Other than that, the efficacy in non-pregnant individuals, its usage during pregnancy may be linked to the hemorrhage-related complications and could exacerbate cases of pancreatitis. Plasmapheresis may be explored in patients suffering from severe hypertriglyceridemia that do not respond to other treatment methods, as it dramatically lowers the TG levels, as in our patient. However, its high cost, thrombosis hazards, biological availability, and catheter-associated inflammation have all limited its broad use. In the case of our patient, multidisciplinary team consistent of obstetrics, GI, endocrinology, hematology, dietitians, and ICU teams were all involved in her management. She was initiated with conservative management, as mentioned. However, conservative management failed, so stepwise approach took us to plasmapheresis, which helped as well lowering the TG levels. However, after rebounding, initiating on omega-3 fenofibrates and statins, all helped to stabilize the TG levels. Neither niacin nor IV heparin was used in her case. However, she was kept on heparin clexane and was discharged on it. So just to conclude our case report, Gestational hypertriglyceridemia complicated with AP is a rare condition with no document guidelines to date. Therefore, its management requires the cooperation of multidisciplinary teams consisting of all the teams mentioned earlier. Hospital admission is necessary when TG levels are uncontrolled with diet and medications. Some medications used in the treatment are categorized as category C, while should be used only when the benefits outweigh the risks. Additional studies should be conducted to provide a standardized set of guidelines regarding this illness for clinicians to adhere to the near future. Thank you for your time. This was Dr. Hamad Saif from King Hamad University Hospital. If there's any questions, I'm here. Any questions?